talk in the session will be presented by Dr. Mohamed Kamal, Assistant Professor of Urology, Menofia University, and Secretary of Endurology Section. He's a shining star in endurology, eminent endurologist, and he did a great job last 2 years in education and the teaching of endurology. He will speak about on-block resection of non-muscle invasive bladder tumor.
السلام عليكم ورحمة الله وبركاته. شكرا دكتور محمد على تقديم الأوفر. Our lecture today will be about why and how to adopt in-block resection of bladder tumors. But at first, we may remember you about our main mission in life. So I think this hadith, maybe some of you didn't read it before. Then back to our lecture. So cancer bladder is a problem in Egypt, and awareness is our duty. So we have like one of the highest incidence worldwide, like 27 per 100,000. So we have to run a lot of epidemiological studies and awareness to our group to warn us about the cancer bladder. According to CDC, cancer is the third most common cause of death in Egypt, and according to the cancer bladder, it is the second most common cancer in males, or the third most common cancer in both sex after HCC of liver. And also, we are having the highest rank of death from cancer bladder in Egypt, reaching to 8,000 per year from cancer bladder. So this is an important topic. And the second point in the lecture is about the tumor resection. We know all that the tumor resection is most important as a diagnostic and therapeutic in some ways. Diagnostic in diagnosis, you have to sample the tumor and you have to do staging and for follow-up, and therapeutic in small-sized TA tumors. And to have this goal accomplished, one of the studies have started in 1980 by a Japanese group, starting to have an in-block resection of tumor by what is called snare. And this was in Japan, I think, by Kitamura, followed by another study from Japan, who is inverted a loop that we see here in the picture to make a new technique for resection of the tumor in block for the bladder tumors. So why in block? As usual, this is getting the tumor in one specimen is better than scattering malignant cells. So we didn't fractionate the tumor, we getting the tumor in a single part, and we all know that decreasing the tumor's privilege and what may improve oncological outcome, although most of the studies didn't prove this. So another one study from Japan again, but was in between histopathologists. And this is one of the high-ranked journal and confirmed that histopathologist was able to diagnose the specimen more fast with the in-block specimen rather than the fractionated specimen. So here's the picture. If you would go and get a specimen and give it in the pathologist in block, he is able to have the epithelium and the lamina propria and the muscle in just one slide. This would make his life easier and would make his error margin less. So orientation for the pathologist slide is better in block in resection. Again, they stated that the slides have a lot of less thermal artifacts, and it gave us a lot of orientation and didn't affect their accurate evaluation, and they also all voted that in block is better for their life. What about literature? A lot of RCTs and meta-analysis, systematic reviews. So the last 3 meta-analysis, one of them from the European Urology in 2020, and it couldn't prove that in block may improve the recurrence rate, but it did prove that it would short irrigation time and it lowers the rate of bladder perforation. The second was informed the Journal of Urology in 2022, and it stated the same. It couldn't prove that in block may improve the recurrence rate, but it gives the same about irrigation and lower cluster time. The last one from less appreciated journal, but it could prove that at recurrence rate at 24 months is less. So these are the literature. The guidelines still allow everybody to do what he wants if he would like to do conventional resection or he would like to do in-block resection. But in the detailed guidelines, they stated these 3 lines that in-block may provide high-quality resected specimen with respect of tumor architecture. This is for the pathologist, and increase the accuracy, especially for T1 tumors, and where the in-block is more appropriate. So in-block resection of bladder tumor is more beneficial for the pathologist and for the patient. So how can we start in block to be on schedule in the lecture? Choose the right size, so it should be less than 3 centimeters. Avoid the places where it's more dangerous to do in block, like choose a basal or trigonal. Avoid the lateral wall and the dome in the start. And again, if you are able to do a CT with contrast before doing this, this would be better. And between settings of the laser, if it's using solium, I use 10 to 20 watt, and if it's bipolar, it's 80 to 100. The steps is to make a circular incision like 0.5 centimeter around the tumor, followed by starting digging deeper, and understand that while you are going deeper, you have to go in deeper in the middle, and at the end, you extract it by a dome basket. Which energy source is better? I cannot say something about this. It's all about RCTs that answer this question, but you can do it whatever you want. For me, I would prefer solium YAG laser or bipolar. This is the first point to explain, like choose the right place. So here, like this case, this is not a case for in-block. So as long as I am trying to promote a technique, I would like to show the dangerous points that you don't do in blocking. Like this case is where the external iliac artery was prolapsing besides the tumor. And I think لو الصوت هيعلى like this case is not a case for in-block. So you can do it by bipolar laser. I would prefer laser for a case like this. I would be so superficial to avoid like making any catastrophic injury. Let's start with the solium YAG laser. From above, and the of the tumor more better. Okay, I can. It's fine. I can do it. Become more expert in block, you can increase the size of the tumor. Sometimes if the site is very big, you can resect part of it by resection, and then to do the basal part, which is the most important part, with in block. And the number of location of blood tumor after some experience is fine, and you can do like 5, 6 in blocks in the same setting, in the same bladder, and you don't have to take an additional biopsy from the base as stated by the systematic view. Here is a more difficult one, I think. And difficult here means one of the difficulties is the size of the tumor, and also if it is a female bladder. You have to know that a female bladder is much more thinner than a male bladder. So take care, like cutting in a female bladder may introduce you to the peritoneum or anywhere if you are not sure where you are going. So this is more difficult, and don't think that this is a perforation. This is the muscles below the lamina propria. Sometimes when it is lateral, it's not wise that you do the complete circumcision, start from one side only, and continue bit by bit, because if you did the complete circular incision, you would find your tumor sunken inside, and you are going to go back after it inside somewhere. So I prefer in difficult cases to start from one side to the other side, do your half circular incision, and when I appreciate this is the muscle, I'm going to start separating the tumor from the muscle and then completing to the other side. Safety is more important sometimes, so if I'm afraid that I cannot do the circle incision in the right way, I may resect the tumor again with a loop if I'm afraid that I may make a perforation. So it's better when you feel afraid that you make a under more than doing a perforation. Doing hemostasis is also fine with laser or bipolar. You can choose whatever you are comfortable with. So also this is the bipolar. So as I said, you can do it with the sodium injection. Nothing different for the sake of time. And